Patient, Patient Engagement Lunchtime Learning Series for the 2025-2026 academic year. Today's session is titled Race, Ethnicity, and Indigenous Identity, Manitoba's Approach to Data Collection and Governance. My name is Maxis Sawyer, one of the patient engagement consultants on the patient engagement team at CHI, and I will host the session today. I would like to do a land acknowledgement to acknowledge that we are gathered on ancestral and current day lands and waters of the Anishinaabe, Ushinawak, Oyate, Dene, Inuit, Inuit, and Métis. In northern Manitoba, we acknowledge the ancestral lands of the Inuit and gratefully acknowledge that our water is sourced from Shoal Lake 40 First Nation. We respect the treaties that were made on these lands. We acknowledge the harms and mistakes of the past and present, and we dedicate ourselves to move forward in partnership with Indigenous communities in the spirit of reconciliation and collaboration. And I hope that today is one of the many steps that I take to help learn, acknowledge, grow, and maybe one day teach. We'll see. A few housekeeping details before I introduce the speakers. The PELL series is accredited by the Royal College of Physicians and Surgeons of Canada as a group learning activity. It may also be eligible for credits towards requirements of other professional bodies. We will have auto transcripts enabled, which can be toggled on or off at any time using the caption button at the bottom of your screen. One of PELL's goals is for the lunchtime learning to be engaging and interactive. Your participation is encouraged and will provide valuable insight and learning opportunities for both the audience and presenters. Please submit any questions or comments using the Q&A feature, also located at the bottom of your screen. And we have a team curating them for the end of the session. Race, ethnicity, and Indigenous identity, Manitoba's approach to data collection and governments will explore the province's framework for managing REI data, the impact of anti-racism approaches on data practices, and the participatory race-based data governance in action. We will be looking at Manitoba's framework for collecting and managing race, ethnicity, and Indigenous identity data, how anti-racism approaches influence the collection, interpretation, and use of data, participatory race-based data governance in practice. And by the end of the session, we hope that you will be able to gain insight into Manitoba's methodology for collecting and governing race, ethnicity, and Indigenous identity data, understand the impact of applying anti-racism lens to data analysis and decision-making, and examine the implementation of participatory governance and its impact on decision-making and community engagement. I'd like to introduce our three speakers. Natalie Buse, who obtained her MA from the University of Saskatchewan and her project management diploma from the University of Winnipeg. Natalie joins us from the George and Fahey Center for Healthcare Innovation, which is located on the University of Manitoba's Bannatyne campus. As a project manager, she is involved in a diverse portfolio of projects supporting both academia and the health system. On behalf of Shared Health and under the leadership of Dr. Marcia Anderson, Natalie has been involved in Manitoba's Race, Ethnicity, and Indigenous Identity Data Initiative since 2019. Then we have Amanda Fowler-Woods. Amanda Fowler-Woods is an Anishinaabe woman originally from Thunder Bay, Ontario, but who has called Winnipeg, Manitoba, Canada, her home for the past 25 years. Amanda and her wife Melinda are mothers of two daughters, aged 19 and 7. Amanda is a faculty member in the College of Community and Global Health in the Rady Faculty of Health Sciences. Her research interests involve understanding the impacts of racism as a determinant of health, the use of Indigenous research methodologies, and the practice of anti-racist healthcare and research. As well, she is the carrier of traditional medicines and works alongside a medicine woman, studying and practicing traditional medicine work and healing for the health and well-being of Indigenous people. Jillian Warwick, she/they, is a Métis public health epidemiologist at FNHSSM. Jill earned a PhD at the University of Manitoba in the field of viral immunology. For 15 years, Jill worked in the laboratories at universities and the National Microbiology Laboratory from Winnipeg to Nairobi, Kenya. However, the constant focus on genetics and chemistry in her work limited her ability to measure the impacts of racism and cultural oppression on infectious diseases, and she moved on, earning a master's in public health at Queen's University. After spending time working as a public health officer in the field of substance use in Northwest Territories and as an epidemiologist working in the surveillance of HIV, TB, and COVID-19 at the Government of Manitoba, Jill found her home at FNHSSM. She participates in many projects such as RHS, the RSS, data sovereignty, data respiratory design, COVID-19 data analysis, and more. Jill is also working part-time on service contract with the Government of Manitoba to analyze health services collected race-based data with an anti-racism lens. She participates in the Race, Ethnicity, and Indigenous Identity Steering Committee, is a scientific advisor for HIRGC, and sits on the board of directors for Candace House. So 3 very accomplished people that we are about to hear from. And Natalie, I will turn it over to you.
Okay, I'm just trying to pop up the screen. Are you guys seeing the full screen or
No, just the slides with
just the slides?
yeah, like not the full
Okay.
slide.
There we go.
Yeah.
All right. Well, thank you, Maxa, for those introductions. So again, my name is Natalie Brise. So I do come into this space talking about data as a white cisgendered woman. I am primarily of European settler ancestry that settled on Treaty 1 lands. So I am part of the provincial REI team. I do act as the project manager. So I do play more of an oversight role across the project. So in terms of implementation of data collection at certain sites, as well as the governance. So I just kind of want to invite everyone to reflect on a guiding question. It's not one that we expect an answer during this session, but it's just to get you guys thinking in terms of what motivates the collection of race and ethnicity and Indigenous identity data in healthcare. So really thinking about why we do this work and who should it serve. But even I'm going to take us back a bit before I go into the project kind of details and where the initiative began to really acknowledge the historical realities that shape today's inequities. And so, it's acknowledging that racism in Canada's health systems is not new and that these systems were built within colonial structures that produce racial hierarchies. So for generations, Indigenous, Black, and other racialized communities have experienced systemic harm through forced relocation, segregated and unequal care, medical exploitation or experimentation, and environmental racism. And that we need to recognize that these are not isolated events, rather interconnected patterns of institutional racism. And really understanding of that history is what helps explain the mistrust that many communities continue to feel, especially when we start talking about collecting data from these communities as well, and how we would use the data to close healthcare gaps as opposed to increasing the gaps or increasing harm that they've already experienced. And so it underscores really why we're using this data has to be used collected responsibly, ethically, and in partnership with communities, and through a commitment of transparency and accountability. And it's also that acknowledgement that racism continues to impact health outcomes, and is not just our historical reality, but it is also our current everyday reality for a lot of our community members. And so Indigenous, Black, and racialized communities continue to face major barriers to safe and effective care. So things like jurisdictional gaps, misdiagnosis, stereotyping, and culturally unsafe practices. And if we look at cases like Brian Sinclair and Joyce Eschwan, these are really reminders that racism with health care has life and death consequences. And these injustices contribute to poor health outcomes, shorter life expectancy, and persistent health gaps. But this is not to say that communities do not respond to these and lead some transformative change. And really what these movements are showing is that communities are not passive recipients of care, and they are the leaders, advocates, and the knowledge holders. And really, when we look at the REI initiative, it's really that representation of a direct response to the Truth and Reconciliation Commission calls to action, particularly calls to action number 19, which urged all levels of government and institutions to close the persistent healthcare gaps affecting Indigenous people through equitable access, measurable accountability, and culturally safe care. So kind of bringing us back into the provincial REI initiative. So I'm going to say that this initiative is led by Dr. Marsha Anderson. She's the Vice Dean of Anti-Racism and Social Justice at the University of Manitoba, and that this entire team, including Dr. Anderson, conducts this work on behalf of Shared Health, but we are supported through a diverse team across multiple organizations. So the regional health authorities, our community membered REI Data Governance Steering Committee, as well as our Indigenous governing partners, one of which is the First Nation Health and Social Secretariat of Manitoba, in which Dr. Work is here as a representative of. So really, when we look at why we've started working with this initiative in the province, what we're really looking is that our purpose in all this is really to collect and govern REI data to measure racism and not race. So assumptions based on race can really reinforce those harmful biases in diagnosis and treatments. And the patterns are not individual misunderstandings, but they're manifestations of systemic racism embedded within our healthcare structures. And it is this racism, not race, that produces very real, measurable, and unequal health outcomes. And so really we are looking, when we've collected this data and through our analysis, is to help identify racial and ethnic disparities across the province, to evaluate services, programs, and interventions, to develop programs to address inequities, to measure system performance, support quality improvement, and plan for services that meet community needs. So this, as was mentioned before, I started on this work and journey with Dr. Anderson in 2019. However, Dr. Anderson has been on this journey for quite a years prior to that. And the strategic direction really for the provincial work through Shared Health really started in 2015. And then from 2019 onward is when we really started to evolve the provincial REI initiative in terms of planning for the infrastructure changes in the healthcare system, as well as the education and training of our staff, public communications, as well as the work that we did during COVID-19, which was really led out of FINISM, who did a lot of the leading work for the Indigenous identity data collection, and then following suit with the race ethnicity, and what we worked with our advisory council to do some real-time REI reporting to understand the impacts and respond rapidly to community needs during that time. So we began to systematically collect REI data in our hospitals in May 2023, as well as the breast screening program within Cancer Care Manitoba. So significantly, this last June, we were able to release our first analysis, which included emergency department data, as that is our more complex data set that we do have some significant numbers that we can do some analysis on, where we co-analyzed and co-developed with our governing partners. And what this analysis really highlighted was that, especially with wait times, there are significant gaps for African and or Black and Indigenous people across the province. And so what this milestone is really demonstrating is what our shared governance and community engagement looks like in practice, that we are doing data interpretation with our communities and working towards ongoing co-development of interventions that can address these gaps. So the last few slides that I'm going to touch upon before I switch it over to Dr. Work to talk about the data in more detail is really around our guiding principles. So these are the foundational pieces that really guide all of our work as we work with this data and with communities, because it reflects our commitment to that rights-based healthcare, anti-racism, its transparency and community-led decision-making, as they are really the backbone of this initiative. So organizations in our thoughts and in our discussions, and when we have discussions with everyone, is that we need to engage in deep, thoughtful planning to really prevent misuse of this data and avoid further harm. So this really means centering on anti-racism, meaningful community partnership, and rights-based data governance. So it's really that lived experience and expertise that has to guide what data we collect, how we interpret it, and how we act on it. And so in January 2023, Manitoba's health system, so Shared Health, and the SDOs did commit to disrupting racism, which was really an essential step in rebuilding trust with communities who have experienced harmful extractive data practices, as the commitment really signaled that the system was prepared to act on disparities, not simply document them and then kind of repeat that cycle over time. I'm also not going to go too much into detail on meaningful engagement and data governance, as those are some pieces that Dr. Fowler Woods will also touch upon. But I do want to say that for us, when we talk about engagement in practice, we are looking at engagement with our community organizations or community members who can speak in that collective, collaborative way with us, is from design to governance and to the analysis of the data. So really, in Manitoba, that meant co-developing a lot of our staff and training in our public staff communications, as well as our data standards with the Community Advisory Council. At the time, it was the BIPOC Community Advisory Council through the COVID-19 work that we did, through adopting those national standards from CIHI and pulling from some international lessons learned, specifically pulling from some work from New Zealand and Australia. And then we are also continuously to focus on building internal capacity in anti-racism, human rights, and cultural safety and data literacy through our work that we are doing with our publicly membered Data Governance Steering Committee. And all of this work is really to push through for that sustained engagement where the community remains at the center of this work. We also continue to work towards being able to include more qualitative narratives, and I think Dr. Fowler Woods will also touch upon this, recognizing that the lived experience provides context and directions for interventions in ways that the quantitative data alone cannot. And so just in terms of that last guiding principle, so it's just to touch upon the Manitoba governance framework. So really our framework, we did ground a lot of this in lessons from Indigenous data sovereignty, that is First Nation data sovereignty, Métis data sovereignty, and Inuit data sovereignty, as well as from that real-time REI analysis that we did during the COVID-19 pandemic to kind of formulate the framework. And really what it does is it's being used to acknowledge that there are risks associated with race-based data, including the potential to perpetuate stereotypes or reinforce inequities. And really to mitigate those risks, what we have been doing is building governance that is community and expertise led, applying that critical equity focused analytical methods, and prioritizing transparency and accountability. And I also want to stress before I end my session is that when we talk about this framework, we are specifically talking about the race ethnicity data that we collect, which includes the Pan-Canadian term for North American Indigenous. Any Indigenous specific data that we collect on behalf of First Nations, Métis, and Inuit data remains governed by those nation representing organizations. And it is not to us or to me specifically to speak to those that specific data set. But so that is just kind of providing that kind of overview of the initiative, but I am going to now switch it over to Dr. Work to talk about the data.
Okay, thanks, Natalie. Hi, everybody. I'm going to sort of touch on two things today and try to not make it too boring. I'm a bit of a data nerd, but I think it's always interesting to sort of reshape how we think about data when you're looking at it through anti-racism lens. So I'm going to talk a bit about the analysis of data with racial identifiers, and then more specifically, collection of and analysis of race-based data in Manitoba. Next slide. Yeah, so that's me. As mentioned, I'm an epidemiologist. I work for the First Nations Health and Social Secretariat of Manitoba. I'm white-facing, but I am of Métis descent. I'm a person with a visible physical disability, and I am non-binary, so I have a lot going for me. And I think my own identity, I think, provides me a sense of humility that I bring to my practice every day. Next slide. So the first thing when I think about data, I think about people who work in data analysis and like the researchers and literature. And one of the things that we come across constantly that are in research and that are baked into our policy and guidelines and stuff that are like built on these research ideas are that race is a risk factor for any kind of illness. It's still being used today, those terms, race as a risk factor. There was this paper I found is a systematic review of developing cancer risk with alcohol consumption, and they looked at 62 papers, and the number one link they found, a risk factor for developing cancer with frequency of alcohol consumption, was race. So if you're of a certain race, you're more likely to develop cancer. And I think it's our job to turn this on its head and say race is not a risk factor for anything. Genetics itself plays a very small role in our overall wellness, and in fact, a larger role is our social environment. And in fact, racism is probably the risk factor for illness in these instances. So I searched and searched and searched for documents where they actually used risk factor measurement of race in certain illnesses. And I think it was like I went through the top 20 papers published in the last year, and none of them except for one mentioned racism as a function of the risk itself, and none actually really went into racism, discrimination, prejudice. I looked at all these different words and couldn't find no conversation about it in any of these papers. So in this world of academia where a lot of people sit, we like to think that there's this like left-leaning sort of liberal ideas that come out of universities, but even here we see that is still not what's happening, and people are too scared to talk about what's really happening when people are getting sick. Next slide. So it is incredibly rare for academia to discuss the real impacts of race on their findings, and in fact just point to race and brush off everything else that might be involved. So it really is important in these conversations when we talk about, and Natalie mentioned, is talking about that this is racism that we're measuring. We're not measuring race. Okay, next slide. So a lot of people think data are sterile, that they're counts or measurements and observations that are generated in a vacuum, and that they can be used dispassionately to inform intervention services, guidelines, and policies. A lot of people think that, especially people working in the field. I probably used to have these thoughts. I'm sure I used to have these thoughts when I was younger, that I wasn't putting myself into any of the work that I did, which is completely untrue. I work at Finism, and one of our sort of things that we like to remind people of is that data has spirit. So we talk often about how each data point or each case represents a person, but that person has a whole story to them and a whole life and a whole community and family. And it's always important to remember that data itself holds some of that person's spirit in it. And it's important to recognize that and treat those data as sacred. Counts, measurements, and observations are always affected by the person designing the data capture. They're always affected by people deciding how the data are going to be validated and cleaned, and always affected by how how they're analyzed. Okay, next slide. So places to address racism when we're talking about data collection itself, considering data capture, how are we asking the question? Like, what language is being used? Are we ensuring that our phrasing is in a non-judgmental way and in a way that doesn't harm the person or make the person feel like if they don't answer the question, they won't receive certain benefits? We found in our work that a script is the best way to go, and training people how to read that script, how to answer questions about why these questions are being asked, things like that. And then we can also address racism once the data are captured during our analysis. So who are we comparing our data to? Are we using that white narrative as this is our baseline that we expect people to meet? Are we using even those baseline comparators when it comes to measurements in the healthcare system? I still remember, like, not even 10 years ago, hearing that the average female's body temperature was lower than the average male's body temperature, and they'd only just discovered that So like just thinking about who's your baseline, where are your expectations lying when you're analyzing data is important. This also goes into stratifications. People don't often think about this, but stratifications is the way of grouping your data or binning your data into certain categories. And oftentimes, specifically for First Nations people, a lot of these age categories actually don't satisfy what First Nations people represent as like elders. So in the province, when we talked about vaccination levels and who's eligible for vaccination, we were talking about like 80 plus, 70 plus, 60 plus. But really, you're missing a good chunk of important elders being vaccinated in the community until you get down to like the 60, 50 plus. And then you're finally hitting those people. So defining your groups when you're doing analysis is incredibly important. And then finally, the types of tests that you do are important. When we do statistical analysis and the different types of math we use, there are a lot of assumptions going into that work, and the assumptions are usually initially created by white men. So it's based on their thoughts and their ideas and their experiences. So it's always important to assess that going forward. Next slide. Anytime people of a certain group are impacted more than another, even if race-based data are not explicitly collected, that group should participate in data decision-making, data analysis, reporting, etc. So when we're talking about any kind of illness where for instance, First Nations person is being overrepresented, really that researcher or that person working with those data should consider and probably should involve First Nations people in the planning, decision making, and carrying out of any of that work that they're doing. It's important to keep that in mind, and that's something that we often repeat at my workplace when we're talking to people about First Nations data. How often does something need to be in a First Nations community for us to consider it overrepresented? Well, there's 10 to 12% of our population is First Nations, so if it's more than 10 to 12% of all people who are experiencing that illness, then you need to involve First Nations people. And really, you should just anyways. Next slide. So moving more specifically to the collection of race-based data in Manitoba, going back to sort of the idea of like the question and what's important to think about just when you're doing data collection itself. It's important to provide the person a reason for the data collection. It's important to have a really explicit, very well stated out consenting process so that you aren't caught up in the future with data that you can't use, and you also are not just signing them up for something, but you're signing out yourself up for something that you have to then follow through on. And it's important these questions use non-coercive language. The responses, when we think about data collection, the best way to capture and the fairest way to capture someone's response for race-based data is using open text, which means a person can tell you exactly how they self-identify and you just put it in or they enter it exactly as they state it. Unfortunately, that is very difficult to analyze because people make spelling mistakes, all sorts of things happen. So we often have to settle for multiple choice. So people are provided multiple choices of race or ethnic identities, and then you are allowed to select which apply to you. In Manitoba, what we've done is we've taken a census, the census data on the most common identities in Manitoba and used those to create our multiple choice selections. Additionally, based on our experiences during COVID, we found that some groups are popping up more than others. So we're like, hey, we're just going to make those a group as well and make sure that they're in there and we're counting them as they are coming to seek healthcare. The question is, are we going to let people give more than one response if somebody feels self-identifies by more than one race or ethnic group? And we also have to have available to them a decline option. Another thing that we decided to do, which again throws a wrench into our analysis, is that we are going to re-ask people over time if they want to change their self-identity. That's because sometimes people do. I personally am somebody who changed my self-identity over time, so I can understand that can be complex in a person over their lifetime, and it's important that we readdress each time we talk to someone. Next slide. So REI and data analysis. So once we've got the data, there are a bunch of pre-analysis processes that we have to think about when we're talking about anti-racism. For instance, what level of response rate is necessary? That's important because we were worried about when we asked the questions, if nobody wanted to answer, enough people declined to answer, would we even have enough data? Thankfully, our decline to answer rate was exceptionally low. Everybody did want to answer the question. People did want their voices heard. But you do have to decide what your cutoff is for what you're deciding is people answering truthfully and you're getting a fulsome data set. We will have to ask, how do we define people who change their self-identity over time? So when and how do we assign an identity to a person? How do we define people who provide more than one identity? So if I say I'm half Métis, half Ukrainian, are you going to represent me in the data as 0.5 of one and 0.5 of another? Or am I a full individual who's getting counted in some way? And then another thing that we had to deal with our REI data analysis is for smaller representations of race and ethnic groups, how do we roll up these groups together to still get a meaningful data set that we can show people and make people accountable for these data, but also not start identifying people within the data set. For the specific analysis, once we get to that point, does the status quo analysis method apply? I can tell you for our analysis, the status quo for measuring wait times did not apply. The status quo for measuring left without being seen did not apply. We had to change them so that we are fully capturing the data we needed to capture for everybody from these different racial groups. What math are being used, again, not the same as typically we would use. We're trying to come at it from an anti-racism lens. How are we treating outliers? In a lot of research, if you're at the high end or the low end, they'll cut you out of analysis entirely and your data point won't count. We kept everybody in to these analyses. Dealing with small data counts, again, we decided to do some rolling up and making sure that everybody's data can be included in the analysis. And then finally, who interprets the findings? It shouldn't be me interpreting the data for absolutely all groups across the province. We should have, and we actually do have, a steering committee that provides support when it comes to interpreting the findings. Next slide. And that's all I have to say. If you have any more questions, I'm looking forward to our discussion after. I hope you weren't bored talking about data too much. Okay. Thanks.
Thanks, Jill, and thanks, Natalie, for bringing us here to this place. And I guess this is where I take over. So I'll be talking about a little bit about different voices that have been involved in this work to date. All right, and next slide. Oh, there's me. So, bonjour, j'appelle Benicia Koydishna Kazmakwa Dodem. So I introduced myself with my traditional name. I am an Ojibwe. My dad is Ojibwe from Fort Frances, Ontario, and we're members of Couchiching First Nation, but I grew up in Thunder Bay and then came to Winnipeg to go to university when I was 19. I'm still here, still at the university, but I'm now an assistant professor in the College of Community and Global Health. I consider myself an emerging Indigenous scholar, so still kind of a baby in this work. And I look to all of those Indigenous scholars who came before me and very thankful for them, as well as all my teachers, my elders, my knowledge keepers who guided me along the way. So currently my work spans a number of locations within the university, including the Manitoba Centre for Health Policy, the Centre for Healthcare Innovation, and on Gomazin, and recently moving into the world of Health Data Research Network Canada, or HDRN. You're familiar with that. So a lot of work going on, but this REI work has been a real passion of mine for a number of years. So next slide, please. So talking about how I got involved in this work, in 2019, I was approached by Dr. Marcia Anderson to consider being part of this work around a new strategy for the collection of REI data. As Natalie mentioned, this was not new to Dr. Anderson, and I think throughout this, we recalled a paper that she had written that we were reviewing, and it was from 20 years prior to when we were reviewing it. So a lot of work has been involved in getting to where we are. But when we started talking about this collection of REI data, one thing that stood out to me is that we could not do this in any way without including the voices and knowledge and perspectives of our First Nations, Inuit, and Métis relatives in Manitoba. So I said that's where I'd, kind of jump in and use my skills to be able to do that work. And so I started my dissertation work in this area. And through that work, I started to always come back to the idea of Indigenous identity and what that would mean and how it would be involved in this type of data collection. And so that's where I grounded my dissertation. And I started to look at, how there has been a past around Indigenous identity data collection being one of harm, mistrust, kind of a dark history there, but how we could shift that idea and that perspective to more of an idea of empowerment, of control over our data, enacting our data sovereignty and our sovereignty as Indigenous people. And so that idea of, resurgence and empowerment came through my dissertation work. And this was really a way of reclaiming our health and our well-being and sort of a pathway to healing through Indigenous empowerment. Yeah, okay, next slide. So that my primary objective of my dissertation was really to understand how First Nations, Inuit, and Métis people felt about this type of data collection, if they had any perspective, any lived experience, anything they wanted to contribute to how this data should be collected, used, protected, and all the pieces of it. Okay, next slide. Okay, so this is one that I think you have to press for, for each of, there we go. So there's a common discourse around REI data collection. So when I started this research, I looked at why people do collect this data, and mostly it was for the generation of big data. So having these health administrative data sets that we can turn to for research, which is really important, but I saw, a more meaningful outcome that could happen for Indigenous people. And this is around that idea of Indigenous empowerment. Okay, and so that's the developing discourse, more around the protection of our data, the ownership, the governance of our data, and how we can do this in a way that honors our rights as Indigenous people. Okay, we knew we couldn't do this through simply adding a question to a form or into a database, a simple, question that you would ask and people would answer. It would be much more than that. We had to include Indigenous knowledge and perspective and oversight in all the processes of REI data collection. In this way, it becomes more of a tool of empowerment rather than that tool for evidence or for surveillance. So there was different ways to frame this work. And I think there's one more. There we go. And so in Canada, when we started this work, there was no federal or provincial mandates for a systematic collection of REI data. So we were really starting from, trying to develop this in the best way that we could with all the knowledge that we had. And since I'd say there was, more development in this area over the last few years, and provinces are working to collect data in ways that are meaningful for them. So there's more happening now, but at that time, there wasn't. And one of the biggest gaps I found was the inclusion of Indigenous knowledge. So there wasn't the literature that talked about how Indigenous people felt about this. So that was that gap that I was going to address. Okay, next slide. So I could talk about dissertation stuff forever and ever, but for time, just a little snippet here of some of the reflections. So Indigenous identity data collection is very complex. It's more, it's going to be more than just having these numbers collected for big data. Everyone that I talked to had an experience of racism within the healthcare system. So I talked to First Nations, Inuit, and Métis folks around this, some community members. I talked to those who were actually data collectors in this area, and I talked to Indigenous leadership, and everyone had talked about racism. Everyone had talked about the idea of needing to protect identity or even shift identity for protection at certain times within the healthcare system. And so we knew it wasn't a simple process, and we needed to definitely include Indigenous voice in this work. We need to include Indigenous knowledge and perspectives. And so we're finding ways to integrate what I'd found through my dissertation work right back into our ongoing strategy. So sort of a very productive feedback loop so we can include Indigenous knowledge that way. We need our leaders and our systems to be in it with us. Everyone needs to be on board. And this involves our leadership, our funders, our workers, our healthcare workers, our academics. Everyone needs to be hands-on in this work to make it happen and to happen in a good way. Part of my dissertation also allowed me to dig into the literature around Indigenous health and healthcare, and to understand, what has been written, what do we think is the evidence out there. So to read the work, but also really dig into it. So who was the researcher? Who's controlling that narrative? Who was even funding that kind of research? How has data been used? Who has had control over it to use it in those? So really a deep dive into the literature. And the outcome was that there are a lot of non-Indigenous people writing about Indigenous people's lives and experiences. And so just, having that critical lens when we're looking at the literature that's out there and what we think is evidence. And the collection of REI data is an act towards reconciliation. So it allows us to begin to address the calls to action, specifically number 19. However, an earlier act towards reconciliation can be to support Indigenous people to be able to move away from the fight. So that constant need to fight, Western ideas, power structures that leave us behind. It's exhausting to always be fighting. So allowing us to move away from the fighting and to celebrate our knowledge, our abilities, our brilliance, to be empowered in this work. And this empowerment is in progress. We see it. Sometimes it's slow and more hidden, and other times, it's right in our face around how our Indigenous relatives are rising up and moving into positions of power. Okay, next slide. So around Indigenous data sovereignty, I think I've said sovereignty and governance a few times. So Indigenous peoples around the globe are now working in this area of how to protect our data. This is really, I think, the last 20 years, this has really picked up since the introduction of the United Nations Declaration on the Rights of Indigenous People. So we see our relatives in Australia, New Zealand, the United States, even Norway now, and Canada coming together to really talk about how to protect Indigenous data and how to honor our sovereignty. So this is really about having collective rights about our data, our people, our bodies, our land, our resources, our traditions, our cultures. This is all data. Particularly we're talking about health data here and administrative health data, but everything about us is our data, and we have to really work hard to find ways to talk about the protection of this data. Okay, next slide, please. So this was just a quote here: "The right of Indigenous peoples to determine the means of collection, access, analysis, interpretation, management, dissemination, and reuse of data pertaining to Indigenous peoples from whom it has been derived or to whom it relates." So Indigenous data sovereignty and governance applies to all aspects of that data cycle from beginning to end. Indigenous data governance is more that act of controlling, protecting the data. And, we look across the globe and our relatives around the world, we are really finding ways to do this in ways that are meaningful. So we have some sort of global protocols, priorities, and frameworks that are happening, but also we're taking that back within our own countries and our own communities to find ways to do this in ways that are meaningful for all of us. Okay, and that's that active governance through all aspects. So we look at how we've been doing this with the REI data. It was really important for us to establish respectful relationships, which led to the building of trust. This was really, really important for us in engagement. And so a lot of the work was a constant sort of feedback cycle where we'd hear from our communities, we'd take that knowledge, that shared instruction into consideration into the work, we'd build something, share it back. People were involved throughout all of this. It was not just a consultation at the end or, showing, look what we've done. It was throughout from beginning to end. We had our communities involved. A lot of lived experience was involved in bringing this work together. I think Natalie mentioned that this kind of engagement work happened through training, through what we were communicating out, through developing data standards. This was all co-developed. There's a lot of diverse expertise that's been involved in this. interestingly, a lot of this work, I think Natalie mentioned, happened during the COVID-19 pandemic. And so while we were trying to carefully do this work very slowly, there was also a need to prioritize doing this to understand how we would govern the REI data collection within COVID-19 data. And so during that time, we were able to bring folks together in a diverse group that we called our BIPOC working group. And they were really a strong voice in a lot of this work. So, even despite the challenges of the pandemic, this group showed up because everyone was committed to doing this work in a good way. And so we just kept meeting time and time again, and everyone was so committed to it. So it was a really important process. But when looking at how we were going to govern this data, we didn't want to start from the beginning. We looked to see what was out there, and Natalie mentioned a few of those existing frameworks. And so looking at OCAP, looking at more of the nation-specific Indigenous data governance frameworks and things like that. And we were able to work together to come together as a steering committee and to develop this framework here that you see the image of. Okay. So for the steering committee, the purpose of the steering committee was really to look at how we were going to oversee the data. They offered valuable insights into what priorities of the communities were. They helped shape the reporting processes. They helped with what we should disclose publicly, and collaborating on recommendations to the health system as well in planning and management. And so we have this beautiful image here. Our steering committee is in the center there, so you see in the white. So that was really, brought together folks with different areas of expertise that were guiding this work. And some of those areas included, let's see here, we had a lot of expertise: critical race theory, human rights, epidemiology, anti-racism, patient engagement, and data analysis, just to name a few. So this committee, played those really important roles in how we were going to work with the data. And as Natalie mentioned, the committee would advise on the category of the Indigenous North American category, but anything that was specifically First Nations, Inuit, and Métis was outside of this committee work. And that data continues to be governed by the nation-based representative organizations. And so this committee is separate from that work. And that's really important. And we like to stress that. And that's an act of Indigenous data governance and sovereignty to keep the control of that data within those organizations. Okay, and so as you move out into more of the colored sections there, the blues, the pinks, these are more of our key stakeholders. So you can see Indigenous peoples and communities, service delivery organizations, community members, and information management analytics. And as you sort of spread out from those, the lighter sections of color there, those are the areas of expertise that these stakeholders bring to the framework. So this framework is guided by principles grounded in rights-based healthcare. And you can see that is kind of encircling the whole framework, which is anti-racism, social justice, meaningful engagement, and human rights. So a lot of work has gone into this framework. And the way that we are continuing to work on this is to do it in a phased approach. So working together to see how this data should be used and accessed and who has access to it. So the phase 1 approach is really around data use for quality improvement through analysis of prioritized areas defined by our governing partners and aligned with provincial priorities. Once we are moving into our second phase, you'll see more of a review of more ad hoc requests outside of these defined priorities. And then later on in a phase 3 down the road, we'll be then looking at use for academic research. So this is a very carefully controlled process. The data is not openly available for people to use. It's very carefully controlled at this point. So we just like to note that this process of the steering committee and the governance framework is nuanced and complex. It's not feasible to have every distinct community in Manitoba actively participating in this process, but we're still, this is a work in progress, a thing in motion. And so we're continuing to work at hearing communities' needs and working towards, their control and governance of the data. All right, I think I'll leave it there. We're getting towards the end. Maybe Natalie, if you want to kind of reflect and come back on this question here.
Yes, thank you, Amanda. So yeah, I just want to re-stress kind of what Amanda was saying at the end, which is that we really do take an iterative approach to this work, and that these are ongoing relationships that we are building and refining and reflecting on, so that we're continuously learning lessons and applying those learnings as we move this work forward, especially as we start also to look at other areas in the healthcare system that have requested or have asked to have this information collected from those from certain programs in terms of mental health, primary care, children's and women's as well. So I'm just gonna leave you guys with the closing reflection, which is again just how might your approach to using REI data shift after this conversation. So I'm going to stop sharing. I think we can turn our cameras back on and answer some questions.
Thank you, Amanda, Jillian, and Natalie for sharing years and years of work within 40 minutes. That was incredible. I loved how you took us through this journey of race being seen as this homogenous thing or this predictor to race being seen as nuanced and complex, and how we can't take one part of a person's identity and make a health assumption onto it that it is not race, but it is racism that is causing these health discrepancies or racisms. So thank you so much. I learned a lot, and I hope to take what I learned from you guys into my work. We have some questions. There was a question about whether or not OCAP principles were followed when collecting this data. Amanda, I believe you mentioned it. Maybe we can talk for a minute about how OCAP principles were followed.
Sure, I can, when we're talking about the governance of this data, that's where we talked about how the First Nations data is controlled by First Nations. And so that is something that was put into place very early on in this work, and those decisions were made through sharing agreements. And I think Jill and Natalie can also comment on this. And we're currently also working with the Manitoba Métis Federation around the governance of the Métis data, and also our Inuit partners as well for Inuit data.
Yeah, so I think if we're looking like really strictly at OCAP, ownership, control, access, possession, ownership is already kind of protected in the province with FIA and with our ability to ask for our own health data. Control is really what's baked into the work here. Where First Nations and other governing bodies who can just make decisions about the data. And then access is a little bit limited. I have access to data. I work for a First Nations organization. So in some ways, First Nations people do have access. It is like limited, but it's there. And then possession, we're not there yet. But the idea is that this is making space for the entire OCAP, for OCAS, for IQ. It's making space for all those principles. We're not there yet, especially around like public health legislation and stuff like that. Like there's still some limitations in place that will be harder to work around and sort of sort of integrate that within like First Nations ideals around OCAP. But I think it's definitely a step in that direction. It's a bigger step than you see most places across Canada.
Thank you. Janice Nesbitt would like you to know that she has a new form we are working on and would like a chance to connect and discuss the approach. Another person asked, is there oversight of acts of racism within health services based on this data? Are there prevention practices in place? Example, a First Nation woman is giving birth in a hospital. Are there mechanisms in place for healthcare providers to remind them of their potential biases, the disproportionate harm towards Indigenous patients? Wondering about the accountability. Thank you so much. This is such impactful, life-saving work.
So I can probably address that question. So in terms of the accountability within the healthcare system, so we are currently working with the clinical leads. We do also work with the lower wait time system improvement teams to try and address that those biased interventions that we can be putting in place in an individual's our workflow. So we are looking at what that can look like. We are having a lot of conversations on the leadership side with that. We are also very much strongly encouraging the anti-racism educational training, as well as taking that journey to really be able to implement your learnings into your everyday work, and kind of taking from those experts in terms of what steps can be taken. So that is work that is ongoing that we are continuously doing. And then again, that reminder that incidences that occur in hospitals should be reported appropriately, and that any patient should feel empowered to go to the complaints office within each region to share their stories, so that those are documented and that we can then put in the appropriate mechanisms in place.
Thank you. And then another question was asked about having open text. It was shared that having open text for those who identify as mixed race is best, though it is easier to have a check all that apply box for this type of data. If we really want to capture the diversity of mixed race in our own research, can you please advise on how you've been able to do that despite the challenges, and the best way to analyze this data?
Sorry, I'm just rereading the question. So there are a few schools of thought on how to analyze these data. And in our initial first pass of the data analysis, and we ran this through our steering committee, we followed the New Zealand model, right, which is creating a hierarchy based on population density, based on need, based on experience. So it's if you select multiple identities, if you select Black and African and white in our data, you are funneled, unfortunately we have to, into the Black and African category, because that is a visible minority group and that we will recognize that you're most likely part of, that where your data are better captured than under the white category. We're doing a hierarchy to do one at a time. Data analysis, that is not the ideal. It is what is done with these large administrative data sets. That is not our plan in the future. Excuse me. As we collect more data and get enough data points, we'll be able to start bringing people out. There are certain categories within Manitoba that are quite common, so we'll be able to measure them and identify them much more easily. But it's complicated. And we want to give everybody the opportunity to self-identify as they wished, with the understanding that we're starting from square one, but we will be moving forward, and in the future we will be able to properly analyze those data. I hope that answers your question. It's not the ideal, but it has been practiced elsewhere, and it's a first step.
And so just to confirm, folks can choose up to 3. Is that still the case?
Yeah.
Okay. So there is the option to select more than one or use the open text box. Is that accurate? Okay.
Yeah, they can. There is an open text box as well. It's just that most people do self-identify within those categories, and then if not, there's an other, quote unquote, other section where they can put in exactly what they want to be identified as. And we do analyze those as well as to best our ability. But again, we're working with open text, so it's learning. We're learning.
We do have one more question, and then I'm going to close the Q&A just for sake of time. It's in mental health, it's not uncommon to see race as a risk factor when completing a suicide risk assessment for individuals. Should we be moving away from using that language? What would you recommend instead?
I can start, but you guys might also have something to say. I think the collection of the data itself isn't the problem. The problem is how we're dealing with the data on the other end, and that is that being of a non-white group does not make you at higher risk for mental health issues. It's experiencing our culture that probably is a bigger impact on your mental health. So yeah, I think there's nothing wrong with collecting the data as long as it's being collected safely. But then it's how we analyze the data, how we report the data, and understanding that just saying that a person is Filipino doesn't mean that Filipino people as a whole have a higher risk for something. It means that being Filipino in this area there might be something that's actually happening to them culturally or within our society that is affecting them. It's just flipping it around a little bit.
And
Yeah.
I would, oh,
Go ahead, Natalie. Go ahead.
I would say that this is also where we would probably stress the importance of involving community into this discussion as to what would be appropriate and how to talk about it and what to say, and that really should come from the communities impacted and what in the groups and the partnerships that your programs have.
And I would just note that, by looking at race instead of racism as that determinant of health, the focus remains on the individual. And by looking at racism, we kind of flip that light and shine the light on the system and start to look at what is happening within our systems that are impacting our health and our well-being that way.
I would like to thank you again, Amanda, Natalie, and Jillian. Someone just wrote in the chat, great information. Thank you to all the organizers, facilitators. Thank you, thank you. I have put a link to a SurveyMonkey in the chat. It will also, when this webinar closes, you are encouraged to fill out the SurveyMonkey. This helps us make PELLs better in the future and also allows us to have the data to continue running these lunchtime learning events. We also would love to hear on these surveys some key takeaways that you left with. So thank you, thank you. We hope to see you again in December, where we will be learning from Dr. Aaron Trachtenberg and his patient partner, John, talk about their patient engagement in kidney health and kidney donor. And we hope to see you then. Thank you.
Thanks for having us.
Bye, everyone.
Soon.
Bye.
Bye.